will have no technical issues, he said, touching wood in every direction in this session. It gives me great pleasure to welcome Professor Katherine Sorsdahl and Dr. Chido Rwafa-Madzvamutse. Excuse me for the pronunciation.
Well done, Richard.
Great pleasure to invite both of you to the AFINet conference as our second keynote speakers. We had Jeff yesterday from the United States, and now you two today from Southern Africa. And you're both going to talk about the role of the family in substance use treatment in sub-Saharan Africa, the past, the present, and the proposed future. I'm particularly delighted because Katherine and I have been trying to work together for at least 4 years now, and we've not actually managed to do that. So this is the first actual thing that we're doing together after all this time of planning and trying. And I recently had the pleasure of reading Chido's dissertation for her, because as well as being a doctor, she's also done, it was an MPhil, wasn't it? In this area. So I had great pleasure reading such an excellent dissertation, an excellent thesis. So I'm really looking forward very much to hearing both of you, and I pass over to you now.
Thanks, Richard. I'm going to try to give it a go and share my screen, and we're going to try to play our pre-recorded presentation. So please bear with me 1 minute.
Good morning, everyone, or afternoon, depending on where you're based. Thank you so much for the opportunity to be here today and for us to share insights on the inclusion of the family in substance use treatment in sub-Saharan Africa. So I'm Katherine Sorsdahl, and I'm the co-director of the Alan J. Fisher Center for Public Mental Health here in the Department of Psychiatry and Mental Health at the University of Cape Town. And Chido and I are going to be co-presenting today, so we'll be passing on the invisible microphone back and forth. So let me hand over to Chido to introduce herself.
Good morning, good afternoon, good evening, everyone. Thank you for this opportunity. My name is Chido Rwafa-Madzvamutse. I'm a psychiatrist, currently based in Zimbabwe, and working in the mental health space here with a special interest in substance use and particularly families affected by substance use.
So just to give you an overview of our presentation, we're going to provide a description of substance use in sub-Saharan Africa and the available of substance use treatments, which includes family interventions. Then we're going to highlight the available research from sub-Saharan Africa on the experiences of family members affected by their relatives' substance use, and we'll actually give a case study or a study on Zimbabwe specifically. And then we're going to provide a snapshot of our future for practice and research going forward. This slide really just shows the prevalence of substance use disorders globally. So globally, you've got 2.6% of the population will meet criteria for a 12-month substance use disorder, 2% in low middle income countries, 3.3% in upper middle income countries, 2.6% in high income countries. I just wanted to highlight that the precise measures of the prevalence of substance use disorders in developing countries specifically is quite difficult to attain, in part because of the limited capacity of these countries to conduct nationally representative surveys. But we have done one in South Africa. It's us and Nigeria, the only two countries that have done it at this time. And we've had a much higher prevalence for substance use disorders in our population at 5.8%. Looking globally, we know that substance use disorders are the second leading cause of disability among mental disorders, with a significant number of years lived with disability attributed to them. We're also seeing that the burden projected by substance use disorders is projected to increase by 130% by 2050. In Africa, we're also seeing the impact of problematic patterns of substance use being particularly high. For example, in 2016, despite lower levels of alcohol consumption compared to elsewhere, the region had the highest age-standardized alcohol-attributed deaths and disability-adjusted life years. which is quite concerning. And we're also seeing early onset of substance use being a significant problem in these countries. For example, in a recent systematic review that only included studies from sub-Saharan Africa, this was 27 studies with over 143,000 participants, they found that the prevalence of any substance use was 41.6%, with alcohol being the most common, followed by tobacco use and cannabis. So we really are seeing a huge increase in our youth. All right, and let me just pass to Chido so we can talk about some of the country-specific problems that we're struggling with.
Thanks, Catherine. So in Zimbabwe, one of the problematic substances that are abused are actually codeine-based cough syrups, which are supposed to be prescription medications, but they do find themselves on the street and have become quite a challenge to deal with. They tend to be cheaper than alcohol, and this has become sort of a drug of use or of choice for youths and young people who may not have access to a lot of money. A lot of challenges that come with bronchial abuse in terms of physical health, a lot of dental problems, gastrointestinal problems that we see, as well as mental health problems, a delirium that sort of comes from this bronchial abuse, and then the addiction to the codeine itself. So a rather unique problem, but definitely a challenging problem for us.
Thanks, Chido. And it sounds like you're getting a lot of your bronco from South Africa as well.
Yes, so bronchial is not produced in Zimbabwe. There are other codeine-based cough syrups that are produced locally, but they tend to be quite expensive as prescription drugs. So these bronchial itself is being smuggled from South Africa to Zimbabwe. So South Africa and Zimbabwe share quite a long border, and there's a lot of sort of porousness in that border that then allows these substances to pass through. We've inherited from Catherine and team.
Thanks, and it doesn't stop there as I move to my next slide.
Yes, so increasingly, possibly over the last 5 years or so, we've started to see crystal methamphetamine becoming a challenge in Zimbabwe. Again, it is because it is slightly cheaper than alcohol. And it was easy to access during COVID because alcohol had been limited in its access in the country. So it has jumped over. It was a problem that was known in South Africa, and they're probably having better control of it than we have at the moment. So at the moment, with the limited resources we have, a lot of challenges in terms of dealing with methamphetamine dependence, even identification of the problems, and then control of it as well. We don't think that there's local production, but there could be. I think a lot of research is still needed as to where it's coming from and how to better control it.
And moving back to South Africa, I think we had already touched on, obviously methamphetamine was a huge problem and alcohol is a significant problem. But we also have a wunga drug, which is basically a street drug that is made up of a mixture of a number of potent and highly dangerous and addictive compounds, but heroin is essentially the core. And this powder is kind of mixed or concoction that includes rat poison, heroin, soap powder, detergents, crushed glass, methamphetamines, and even antiretroviral drugs, which are what's treated HIV. So it's basically everything thrown into the kitchen sink. And it basically results in a very fine drug, a white powdered substance. It's often smoked, sniffed, or injected together with marijuana or tobacco. And I think one of the reasons why it's being used is it's very cheap. I mean, it sells between 30 to 45 Rand per hit, so it's about $3. And the normal user requires about 3 hits a day. So if a full-time user would have probably spent 3,000 Rand, about sort of $300 per month to support their habits. So this is what we're seeing moving forward. Although similar, I think, to Zimbabwe during COVID, we definitely saw an increase in patients for methamphetamine use. So apart from the direct burden due to alcohol and substance use disorders that I described earlier, it also leads to many other diseases. So it's contributing significantly to injury and chronic disease. With over 3 million deaths a year are linked to alcohol use, while harmful use of alcohol is linked to over 200 diseases and injuries. in South Africa and in many African contexts, alcohol is really associated with other transmission and progression of HIV and other infectious diseases such as tuberculosis, which are diseases that are really impacting on our population and have causing huge burden to our system. Also, just to mention that intentional and unintentional injuries from road traffic accidents, interpersonal violence and suicides are very been linked to alcohol and substance use. And in our context, it's really quite severe. So during the certain phases of lockdown in South Africa, the sale of alcohol was banned. So we had a bit of prohibition at certain times during lockdown. And the argument was that the number of alcohol-related hospital admissions would mean more beds available to treat COVID-19 patients. And that is exactly what had happened. So we found that a lot of the reasons why people were presenting to emergency rooms were alcohol-related, from violence and trauma. So just simply taking alcohol away eased up the beds for COVID. So this slide is a diagrammatic representation of an optimal mix of service components for a comprehensive substance use service. And this is essentially a WHO model, and they're recommending a continuum of care with specialist service forming only a small part of the treatment service. Having a small part of the treatment service being reserved for those with chronic and more severe problems. So if you're looking at this triangle, you can see that the most numerous services should be self-care management, followed in ascending order by informal community substance use services, interventions offered at primary health care, and more formal substance use services offered at outpatients, short stay inpatient, and long stay inpatient if the problem is very severe. But what we find in many countries is that our pyramid is essentially upside down. So our existing substance use treatment services really rely heavily on the provision of high threshold drug rehabilitation services offered by specialist service providers. So it really is very similar. It's similar to our mental health treatment. So I think that's obviously part of the legacy here, even though it's offered in different countries, whether it's Department of Health or Department of Social Development or Welfare, but we're still seeing the same triangle upside down. Looking at this is the same slide I had before, but really looking at the amount of treatment that is being offered. So if you look globally, 2.6% of the population would have had met criteria for a substance use disorder in the past 12 months. 9% highlighted that they had a perceived need for treatment or wanted to access treatment. This is 29.5% accessed any treatment. Here is 7.1% received minimally adequate treatment for substance use. And so just to highlight that minimal adequate treatment for a substance use disorder was defined by 4 sessions from a trained medical professional and 6 from a non-medically trained professional, because we have a lot of task sharing in many countries as well. Just to highlight that they didn't look at the type of treatment offered, but I would hypothesize or just be mindful that whether or not this was evidence-based is up for debate. But looking at this, you can see that 1 in 10 people in high-income countries, 1 in 24 in low-middle-income countries, and 1% of those in low-middle-income countries really only access care. So there's a huge treatment gap for substance use disorders. And let me pass to Chido for available treatment in Zimbabwe.
So similar to what Katherine has explained about the upside down pyramid, it's very similar to what is happening in Zimbabwe. A lot of the services are available in tertiary psychiatric units. Substance use services are very limited and mostly offered in private care and very expensive. And there are community-based services, but when it gets to more intensive interventions, it's usually not based in the community. And within the mental health services, substance use disorders are treated as part of the mental health service. So this makes it very difficult for a non-psychotic substance user to get appropriate care because they're cared for in the same place as someone with a psychotic mental illness, someone with depression, someone with anxiety. Everything is treated in the same center. So that's usually inappropriate. It makes it very difficult and makes clients who may be seeking care hesitant as to where to get care. Just another mention of the community-based services. So a lot of 12-step based services that are available. Challenges with that obviously are when those community-based services want to refer to the formal medical system, they often don't have much or of an option or options in terms of where to refer to. So those are some of the challenges that we face in terms of available treatment.
Thanks, Chido. And we wanted to also just have a slide specifically on whether there's any family involvement in our current treatment models. But as you can see, our current treatment models are already quite limited. So surprisingly or not surprisingly, essentially the answer is no. When substance use treatment protocols are available or there is some kind of program, they usually are focused on how those family members can support their friend or family member living with the substance use problem. And there's far less attention paid to the impact of a person's substance use, or how the person's substance is impacting on the family and the supporting the family themselves in their own rights. It's quite limited. I mean, Sanka, for example, is one of the key service providers in South Africa for substance use services. They provide inpatient and outpatient services, and they do offer a 6-session program to family members at some of their offices on the weekends. And these programs aim to provide family education on having to manage a relative with substance use in a more constructive manner. So I think we're not at that stage where family members are being provided with any kind of support for their own coping and for themselves. And Chido, what's it look in Zimbabwe?
Very similar again. Families are involved, particularly in the state services. Families are very much involved in terms of admission to care, during the admission itself, and in the discharge preparations. The families are involved, but again, it's more in terms of access to care for the substance user rather than care for the individual family member themselves. So we often see family members may come in and they've got their own challenges, and then that care is really as a sort of as an aside rather than something that should be a key part of the care that we're providing. It's sort of, if someone breaks down, then they get counseling or get referred to a counselor or psychologist who will be available for them, but it's not routine. Yeah.
Thanks, Chido. Right. So why we kind of refer to affected family members as the silent sufferers. So we know that substance use disorders affect not only the individual using substances, but also the health and emotional well-being of the family. So available research, although predominantly done by high-income countries and some low-middle-income countries, and by many of the colleagues on this call, we know that memory studies have found elevated rates of mental illness and stress amongst affected family members as a result of their relative substance use, and many descriptions of fracturing of family relationships, the loss of trust, isolation, threats, violence, and blame, which often accompany this. So unfortunately, there hasn't been much research, as we're going to find out, with affected family members in African countries, but we will describe what we do have available. So let me pass to Chido for that.
So as Catherine is saying, there's very limited research on affected family members in Africa, and almost all of the studies that have been done in South Africa. There have been a number of dissertation studies and also studies that just focus on the experiences of parents and siblings and family members affected by substance abuse, but unfortunately very limited in terms of Africa being such a large continent, and almost all the data that we have is coming from one country. So we'll just move on to a study that we then did. I did this together with Catherine. This was part of an MPhil study that I did with the University of Cape Town with the Center for Public Mental Health, looking at family experiences and the role of the family in development of substance use in adolescents and young people in Zimbabwe. And just a background as to where Zimbabwe is. So it's a Southern African country, and you can see there on the map where exactly we lie. But we've got a significant border with South Africa and Botswana, as well as Mozambique and Zambia. And it's a low-income country with a population of almost 14 million, but only 15 psychiatrists, and just over 1,000 specialist mental health nurses. So very, very limited in terms of mental health care professionals in the country. We train our own psychiatrists and we train our own mental health nurses, which is good, but it will take us a long time to get the sort of ratios right in terms of population to mental health care professional. There are 4 government referral psychiatric units that offer both in and outpatient psychiatric services for patients with a range of psychiatric conditions. And alcohol and substance use are then treated within those psychiatric services, plus the private services that I mentioned earlier. So the study was focused on families of patients who were admitted to one of the referral psychiatric units in Harare, which is Harare Psychiatric Unit, which services the northern regions of Zimbabwe. And it was an exploratory qualitative study. We used semi-structured interviews to elicit the experiences of 19 family members from 19 different families. And the study population itself included parents and other family members. And the patient who was admitted, we had limited that patient's age to 24. And they needed to have admitted to starting the use of substances below the age of 18. So this is early onset substance use we were looking at. And they were being currently managed for a substance-related condition in the hospital. The patient gave assent or consent, depending on their age, for us to talk to their families. And the families themselves gave informed consent for us to do voice-recorded in-depth interviews. And these interviews were recorded, then transcribed verbatim. The transcriptions were then translated, if not in English. Mostly they were in Shona, if they were not English. And then once the transcriptions were translated, we used NVivo to aid us in our analysis. And the participants of the family members who we talked to, in terms of age, ranged from 25 to 65, mostly women, just probably reflecting the burden of care on women generally. And then most of them were married, and significant number were employed. And they were mostly the parent, the biological parent, either the mother or the father, but we had some grandparents, and we also had aunts and uncles, a sister, and also a spouse of one of the older patients. And the main themes that came out from the data we collected was, number one, what the perceived causes of substance use in young people were. And there were some individual factors, including self-indulgence, lack of discipline, and then a number of environmental factors, including the community accessibility and or how the community viewed substance use. And then also family factors came in under environmental factors. Then there was the discovery of the substance use itself, where families noticed changes in behavior and the effects of the substance use, and reports that came in from other family members, from neighbors, from teachers at school. And then discovery through a health-related, substance-related health crisis as well. And then in terms of impact of the substance use, there were things that impacted the individual themselves, the young person, in terms of their health, in terms of their mental state, and then obviously the impact on the family, which was very important, challenges that the family had in terms of finances, in terms of their own emotions in dealing with this, in terms of occupational challenges that happened, in terms of social problems like stigmatization that also then happened. Then families coped in different ways. Some were engaging, they kept very much engaged in treatment, and very much engaged in trying to monitor the young person and as a way of coping. Some were tolerant, they just really tolerated the behavior, accommodated it as much as they could. And then there were those who disengaged and surrendered as a way of coping and sort of preserving themselves. Families suggested a number of interventions that could help at community level in terms of accessibility of drugs in the community, in terms of other interventions that could help in terms of young people getting meaningful work to do, as well as family-led interventions where they highlighted some family values that could change approaches in terms of communication, in terms of how families interact with each other as interventions that could possibly help with the substance use challenges. And just to go into a little bit of detail about some of the themes that came out. So with the perceived causes of substance use, some participants really did think that this was a self-discipline problem, and that young people were being were self-indulgent, and they thought that there was a lack of discipline as this is as a cause. They also thought that it was just mischief and experimenting with substance use, and some thought it was rebellious behavior, but others thought that this was actually a result of stress. Highlighting that the death of a parent or maybe physical and emotional abuse could actually result in a young person then turning to substances. Like the quote that I've mentioned there, where the participant mentioned that the young person was physically abused by his father as he was growing up, and the uncle thought that it was really the cause of why the young person was now using substances. Environmentally, there were a number of factors. The community-related factors included easy accessibility and a community normalization of substance use, where communities would be quite permissive and would supply substances to young people, even those like alcohol, even to those who are underage. But they also highlighted that poverty was a challenge and unemployment, where young people had very little to do and they would lose hope and then turn to substances as a way of coping. So they believe that this was a factor. In terms of peers, they highlighted that friends and peers really influenced young people to use substances. Bad friends, in quotes, that's what they mentioned. And also that young people would think that it's quite fashionable to use substances. That was something that participants also reported. But they also reported that where there was family discord, this could drive young people towards their peers, and then as a way of escaping from the problems at home. And we could imagine with some of the socioeconomic problems happening in the country, a lot of bickering in the homes, and then young people turning to drugs as a way of coping with the situation. Spirituality was something that came up, where participants also believed that this could be more than medical. They thought that it could be a spiritual problem, maybe an avenging spirit or witchcraft or unhappy ancestral spirits that are driving young people into substance use, because they found the substance use and the behavior very disturbing and very confusing. And then finally, family factors were a big contributor. 14 of our participants actually believed that family discord and poor family communication, disintegrated family systems, and were potential causes of the substance use. Poor supervision came up as a key issue, that young people were not being supervised as they should be, whether it's because they were orphaned or some of the parents were distracted in some way with work, or distracted because of their own challenges in terms of financial problems or marital problems. They then don't supervise the children and young people well enough. So this is some of the beliefs that they thought were to blame as well. And the breakdown of families was highlighted, and the absence of fathers was also highlighted as an issue. And issues about poor family values came into play, where they believed that family members could be the ones actually exposing young people to substances in the home, and where substance use is actually condoned in the home. And because if substance use is used substances are used in the family, it then becomes more difficult to reprimand young people when they start using substances, and it becomes a normal part of the family culture. So that was then mentioned. Then a bit more detail in terms of discovery. Families discovered the substance use in various ways. Notably changes in behavior and the effects of the substances themselves. They would notice young people staying away from home more than they did before, challenging those in authority, and really the change in how they relate with others, a lot of conflict with family members. And then they would also notice what would be the signs of intoxication or withdrawal from substances, such as disinhibited behavior, restlessness, drowsiness, that they would observe and sort of relate to possible substance use. And a lot of the family members actually say they didn't know what was happening initially. Some of them thought it was actually a health challenge, the medical problem, a medical emergency, and they would actually rush them to hospital, only to then find out later that this was actually a substance use related issue. And reports from family members was also a way of discovery where other family members, friends, neighbors, teachers would be the ones who informed them, particularly school authorities, who would notice changes in behavior, deterioration in performance in school, and then inform the parents or families that something might not be, things may not be okay with the young person. And the family witnessing the substance use themselves was something that also then happened. Very interestingly, the discovery through substance-related health crisis was quite the issue. There was a number of family members who mentioned that they went to hospital because they thought there was a medical emergency, like in the quote there, where they thought that the young person must be severely ill or maybe might even be dying, and then they were then informed about the substance use, or sort of discovered it by accident through the medical professionals there. And there was, in terms of the theme on impact, there was a lot that impacted of impact of substance use on the young person, but also on family members. So the young person would have challenges in terms of self-care and physical appearance and mental stability because of the substance use, poor performance in school, and disruptive behavior, aggression, both verbal and physical aggression towards family members and others in the community. But in among family members, physical health challenges were also there. So a number of family members mentioned hypertension and having challenges controlling their stress as a result of having to deal with substance use in their child or young person in their home. And emotional distress, participants mentioned fear, disappointment, feeling angry, helpless, hopeless, and a lot of self-blame as well. That was some of the challenges. And then the relationships within the family deteriorated. There was a lot of financial strain as well, which was significant in terms of having to replace things that may have been stolen by the young person, pay dealers, but also get treatment for the young person, which we mentioned that a lot of it is private care and it's expensive. But even for state care, which is free, getting the young person to the hospital, buying any medications that would be requested by the professionals there, really put a financial burden on families. And then strain in other relationships with the other siblings of the young person, or stigmatization from the rest of the family who wouldn't really understand what's going on in the family. Yes. So families coped in various ways. The engaging families tried to provide a lot of encouragement to find different ways of living, ways of changing their life to the young person. They would be vigilant and try and monitor the young person in terms of trying to help them change. But then there were also tolerant families who coped by just accommodating the behavior. They'll just let the young person do what they do. They'll just allow them to continue the drug use and the behavior of the accommodated as much as they can. But then there were also disengaged families who felt that they needed to surrender, participants who actually left the family in order to cope with the situation. And there was also a mention of spirituality here, where families would surrender everything to God, and even if they feel they failed in some way, and then just pray that things would return to normal at some point. Then the families suggested certain interventions that could help with the situation in terms of the substance use and the impact on the family. And we separated these into community level and family-led intervention. So at community level, families suggested provision and promotion of the use of the medical rehabilitation services. Families thought that provision of opportunities to young people for gainful employment would also help in terms of young people not getting involved in substances or finding some sense of hope beyond the substances. And then awareness campaigns to raise awareness about substance use. A lot of the participants had not been aware that the changes they were seeing were due to substance use. It took them a long time to figure that out because they didn't have that information. And then they also mentioned punitive approaches such as arresting and punishment of dealers severely, because they felt that there was a sense of condoning substance use within the communities. Then family-wise, families suggested being supportive and kind and improving communication in the family, and also working on their family values themselves, and monitoring of young people, perhaps moving or changing neighborhoods able to break the ties with the drug users. And then also families mentioned that spirituality would help young people who are struggling with these situations.
Thanks so much, Chido. I think, even just looking at the limited available data we have from sub-Saharan Africa, including your thesis, I think it's very clear that there really is an urgent need to address the physical and psychological health of affected family members. And if you just look at the estimated population of South Africa, 50 million, and approximately 5.8 of South Africans suffering from the substance use disorder in the past 12 months, you could estimate potentially that 2.9 million people may benefit from substance use treatments. And if you're looking at the estimates given by our colleagues here, probably on the line, that about 2 affected family members might need some support, this would be 5.8 million people who are affected by their relative's substance use. This is a substantial amount of people who would benefit from any kind of support for themselves. I think this need is also highlighted in many of our NGOs and other populations around us. So, for example, the South African Depression and Anxiety Group, which is a non-profit organization that runs suicide lines, but is also responsible for the Department of Health or Department of Social Development's 24-hour substance use helpline. They've found that 82% of all the callers they get on the substance use line is a family member phoning on behalf of their children, mostly. This is a huge number of people requiring support. Yet for the affected family members in many of our countries, including South Africa, it's essentially non-existent. And given what we know, there's good evidence that affected family members have very high mental health needs and require help in their own right. In addition, if they do receive the support and help, they would enable them to cope more effectively. There's evidence that has a positive effect on the family system, and hence also the relative with a substance use disorder, creating a suitable home environment that really supports recovery of the substance user. So I feel very strongly that addressing the mental health and distress of the family themselves is a really good place to address the cost of this kind of hidden burden associated with their relative substance use disorder. Over to you, Chido.
There's, as Catherine was highlighting, there definitely is an urgent need to address the direct care to affected family members. But I think it starts from policy, and one of the implications in terms of some of this research that has come out is there needs to be a clearer policy directive in terms of access to care and structured support for family members, because there's a lot of emphasis in terms of policy concerning the individuals who are affected themselves. Recently in Zimbabwe, there was a publication of a treatment protocol or treatment guidelines for substance use disorders in the country to try and bring some structure to the care that is being given in the different sectors of society, including community interventions, including the interventions in private care, as well as in the state facilities. But that those policies are usually directed at those who are in treatment, the individuals, but not including family members and what support they can get. There's also a need for policy support for programs and reducing the risk of disintegration of the family. So we know, I think it's becoming, a lot of the research is coming up to say the strength of the family is needed in terms of prevention of substance abuse, but also for families to be able to support someone better when they're struggling with substance use issues. But there's not much policy in terms of how to help families become stronger. And then policies that support capacity building of parents and caregivers in empowering them to better care for young people. So a lot of the care for not only substance use, even mental health problems of young people will be centered in the home, and the parents and the caregivers are the ones who have the most burden, but they've got very little support in terms of capacity building and helping them even to identify the substance use problems, and then to also help in the care. Then issues about practice. So in day-to-day practice for those who are dealing with affected family members, the need for interventions that help family members to improve their coping skills and their parenting skills in order to reduce their own psychological distress and improve their family functioning and communication. There's a lot of assumptions that parents know what to do, when in fact parents may need a lot of support and interventions that aid in that. And then there's a need for routine screening. So the screening that is done usually for the affected, the family member who's the substance user. But there's very little that's done routinely for the affected family member. So sort of people know that they probably are stressed out, they're burning out, but that routine screening is not done as part of care. Yet the family is the basic support system for the person who is struggling with the substance use problem. And when the support system is burning out, we are not reacting appropriately. And then there's a need to support programs for families of substance users, just programs dedicated to the families. And looking to the future, there's a need for us to obviously look at research. And as you saw, there's very little research done in sub-Saharan Africa. Most of it had been done in South Africa, and this one study now done in Zimbabwe. So there's not much information. And there's a need to look not only at how families experience these challenges and the challenge, but also looking into interventions that could be done to help families, local interventions, as well as adaptation of existing interventions like the stress strain coping support models, the 5-step method, adapting that to the local setting, adapting it to the local languages and the cultural setting that is there, which we think would be something that could be done. That is a practical approach to helping families cope. So a special thanks to AFINet and to all of you for listening and for this conference, attending this conference. Thank you very much for the opportunity, and we hope that we've contributed to the body of information and hopefully expanding our understanding of how affected family members are doing.
Thank you very much indeed, Katherine and Chido. Katherine, are you finished as well?
Yes, apparently so. I wasn't sure what was happening, so I could see the screen, but I couldn't see any comments or anything. It's tricky when you're presenting.
Well, one of the joys of Teams. So we do have a few questions which have come in. I've got 3 or 4, but I won't jump in. Let's take Ed first. Ed says funding is always an issue everywhere, and I wonder how AFINet, for example, could help with resources that reach family members at a low cost. YouTube resources, online self-help. Do you think that would be something that would be of use in sub-Saharan Africa?
Yeah, do you want me to go first, Chido? Or do you want to?
Yes, go ahead. Yeah.
Yeah, I think it's something we've been trying to explore, and I think, you know, when we think of SADAG, with they have that line. So in a way, if we could find a way to build capacity so they could actually deliver it, would be an obvious. And they're already volunteers. We would just need to build their capacity, and the family members are already calling them. So I think for me, that was be kind of the first step to we already have a pool of a population that needs it. So maybe there's a way that we could leverage that. And we do task sharing in South Africa and in Zimbabwe. It's the only way. I mean, Chido's one of the only psychiatrists in the entire country where she is. We really got to think of more innovative ways to build capacity. So Chido had to come to South Africa to do an MPhil as an example. So those kind of things. I think we need to find a way to be creative.
So do you think that things like online resources are, because we've heard quite a bit from various speakers this morning and yesterday about the development of online resources, doing sessions on Zoom. We heard from Pauline about how instead of moving from a Christchurch in New Zealand-based organisation which did face-to-face work and group work, they now do Zoom and they cover the whole of North and South Island. Is that the sort of thing that you think might be useful in both in Zimbabwe and South Africa, and of course all the other tens of countries in sub-Saharan South Africa which are not your two? Chido, what do you think?
I think definitely in Zimbabwe, and I think in South Africa as well, there's quite a high cell phone penetrance. Maybe not smartphones yet, but definitely even in the rural areas, you'll find everyone's got a cell phone. So there could be some leveraging of technology that we could do. Something else that I'm thinking is sort of training of trainers, so a cascading of information, because we do a lot of task sharing with community health workers, with lay counselors, which could be done with teachers, with parents even, where skills can be sort of cascaded down, and then we improve care, and then a small amount of resources can be spread, quite widely. But yes, technology is something. With COVID, I think we've all adjusted now. There was a lot of resistance to online learning and online conferencing before, but I think people have adjusted now, and it's something that's quite acceptable. Another thing that happens, which is quite interesting, is WhatsApp conferences. I don't know if you've ever heard of those, but they happen in Zoom. So people may not have data for Zoom, but they have data for WhatsApp because it comes as a package, it's a bundle package from the internet providers. So people can actually agree that we meet like we would be meeting today, Richard and Catherine and everybody. And when we say we're meeting at 12 and we're all on WhatsApp at the same time, and then you put your voice notes and little videos and you answer questions. And it's very interesting how I've been asked to do training like that for lay counselors, for parents, and it's worked. It's low cost and it can be done. So there's a lot of things that we can do leveraging technologies.
That's incredibly interesting, actually, as I hadn't heard of using WhatsApp in that way. And yet, I mean, as you say, it's something that's available. In my work in India, almost everybody seems to be on WhatsApp, and people prefer using WhatsApp for the reasons that you said. But the idea of running a conference or a big training using WhatsApp is a very interesting idea as well. I should say that Dave and Tina have put on the website a number of free books and other resources, which will be circulating later anyway. But I just that this idea of using technology to help us is, I think, a very important one. Catherine, do you want to come in here?
Yeah, I think we've kind of used technology in varying degrees. I think one that worked well for us, Facebook Lite is free in South Africa because they've made it free. It uses much less data. So we've had apps don't necessarily work because they take up a lot of space on the smartphone. A lot of the adolescents share phones, etc. So we found that this Facebook app, we actually used a chatbots to provide basic CBT, motivational interviewing and problems, and it worked really, really, really nicely. But when we did try to do kind of treatment over the phone, it was very challenging. Even if they did have a phone, there was always issues of confidentiality with there's 5 or 10 people living in one house. There was really, so I think for us, in South Africa anyway, we're trying to leverage technology to make the contents and make it sort of more accessible, but we're having to kind of have a hybrid approach.
Okay, so Steve from New Zealand has got a question again about capacity, really. He says, if there is such a limited pool of qualified mental health workers, for example, with you, Chido, in Zimbabwe, what was it, 15 psychiatrists and 1,000 mental health nurses for 15 million people. He says, how will you get the people to train or to give support to family members? he says it's all really about capacity building, isn't it? Even with research on local interventions, how do you get the people to train the people to support the family members? Any ideas about this?
This is something that's already happening. Maybe not in the substance use space yet, but definitely within the mental health space. So if you've heard of the friendship bench, this is an example of task sharing that has been done for common mental health problems, mostly depression, anxiety, those sort of symptoms. And this is training what we call community health workers. So these are lay people. They're not trained in, they get very little training. Most of them have got a grade 7 education level. They're older members of the community who are educated in a packaged way by the Ministry of Health to just be able to communicate with the rest of the community about common health issues. And recently, or maybe not recently, over the last few years, they've actually been incorporated into mental health as well. So it's being rolled out now, and it's been shown to be effective for depression, mild depression, to be treated using solving based techniques in this way. So you can literally task shift to that level, to a community health worker. So we've had to learn to task shift because there's just not enough of us. So we are still pushing to train. We train our own, so we try and train as many as we can, and we try and encourage as many people to take on mental health and substance use training within the country. But we've had to just change our approach in terms of getting to as many people as possible. So everybody becomes a potential target. So the community health worker, the teacher, the parent, everybody can help. And if you get enough skills and then you put in the structures, this is something that hasn't happened yet though, put in the structures for that stepped care approach. So if the community health worker gets stuck and now they need to refer on, that system is still a little bit shaky because the structures are not in place. But definitely you don't need as many mental health professionals in a system like that. That's something that has been shown to work.
I mean, have you considered utilizing, I mean, the friendship bench is a fantastic scheme and has got very, very good publicity, I think. Have you thought about utilizing that within the families of substance user population?
Well, they have started. I know they've included a module on substance use for the community health workers. So there is a little bit of information that's given, but probably not enough. This is something that can be explored, I think, with Prof. Chibanda and his team. They are very open to diversifying the friendship bench. So it started off as a program for adults. It's now open. They've opened up a youth service under friendship bench again in colleges. So it's continuing to diversify. So I don't see why it couldn't happen. I think it's just adding another layer. Although in saying that, something we always need to consider is not overloading the community health worker. So not getting to a point where they're having to do a lot, because they help with TB awareness, HIV awareness, maternal and child health issues. Now we've put mental health. So that's something that we always need to consider. Other cadres that could be considered are social workers. So we've got a lot more social workers. They're not necessarily clinical social workers. We've got a basic social work program in several of the universities, and that's something that people have highlighted, that it's a cadre that could be of use in terms of just helping the community health workers and helping to buffer them from too much burden. Yeah.
And maybe just to add to what Chido's saying, so we've done something slightly different in South Africa. I know we have slightly more resources, but we needed to make our arguments transdiagnostic. There's so much stigma for alcohol use and substance use, but when we integrate it into common mental disorders, it's much more acceptable to the primary healthcare. So we have a similar problem-solving therapy that we use, and we add on emotional interviewing components. So we screen for alcohol and depression and anxiety, and everyone gets kind of a slightly tailored intervention. And the camps, I mean, in South Africa and Zimbabwe, we've had HIV counselors for a very long period of time. So we kind of have that kind of cascade approach already, that we're just leveraging those experiences. And it's working very nicely, and the stigma is much lower. People would prefer to get access almost at primary care. There's so much stigma for those sort of high intensity services. So yeah, we're sort of trying to take a different approach.
I'm interested that both of you have talked about using professional or semi-professional cadres in order to develop services, and it comes back to one of the slides that you showed, Chido, where you were saying that one of the imperatives was a policy-driven agenda, and that seemed very much a sort of to phrase it in this way, a top-down approach, that you get the policy right and other things fall from that. And I just wondered about the alternative, because what's happened in many countries is very much a family member focused approach moving upwards. And so family members start to get together to help each other. And from that, they develop organizations and they in the positive sense of the word, professionalize the organization in that they try and make sure everyone is trained using a similar model, but it's still very much family member led. And then that leads to the policy drivers, because policy people start to notice that there is a groundswell of work going on within the community. So what's your opinions about community-led as opposed to policy-led change?
I think it's actually an excellent point you've brought out, Richard, and it actually reminds me that right now we're seeing a blossoming of a lot of community mental health organizations, which really do start from users, from service users, from people with lived experience. It wasn't really there about 5, maybe 7 years ago. We didn't have too many. We had like maybe 1 or 2 organizations that provided support in terms of mental health, but it's almost ballooned in the last 5 years. A lot of people are becoming more aware. I think it's the internet accessibility and people just being able to do more in terms of being on social media and getting a lot of attention on issues. So we've got organizations for anxiety, for depression, for substance use that are, mushrooming everywhere. And I think it's exactly what you're saying, that it probably will work better that way. That if people with lived experience get empowered, and this is something that's on the ground, there's some work that's being done in terms of trying to sort of pull together everybody who's in the space, trying to figure out who's doing what, and start to have some sort of empowerment that's happening to these organizations. I know the WHO came in and did quality rights training. I don't know if you've heard about that, which is just set to improve the way mental health, people with mental health problems are treated in terms of human rights. And it was actually the service user organizations that took that on. And they've literally just blitzed the whole country, and it's very interesting to see. And hopefully, like you say, that will cascade to pushing the policymakers to start to see that there's actually an issue in terms of affected family members, and that more needs to be done.
Okay. There's a lot of stuff that's come up on the chat, a lot of resources people have put up. A lot of thanks for both the excellence of your talk, but also how that's led to all these sharing of resources and very, very interesting ideas. I will be summarizing all of the chat when we publish this stuff on the website later. We're just about at the end of time. Thank you so much for keeping to time. Can I thank both of you very much indeed for a very interesting and stimulating talk. What's happening in sub-Saharan Africa is tremendously interesting, because when you describe the findings of your research, for example, or of the research that you showed from many student dissertations from South Africa, and I'm familiar with many of those as well. What that shows is really underlining the huge effects on family members, and how very similar these effects are, as we have found repeatedly in our research in many different countries, how similar these effects are on family members across the world. You're working in very challenging environments with very, very few resources, very, very few services, and having to start from the very bottom, really, in terms of developing effective interventions for helping huge numbers of family members who are really badly affected, and getting more family members, because unfortunately both alcohol and other drug use, and I'm sure we didn't even touch on that, but I'm sure gambling and problem gambling will be very high within sub-Saharan Africa as well. So the impacts on family members are unfortunately only going to get worse. It's very, very nice to know that both of you and obviously your colleagues are working hard to develop things in your countries and in other countries, because I mean, you two are at the forefront of what there is, and there's not very much. If you think about all the other countries, there's even less. So thank you so much again for all of this. Do stay with us, and I'm very happy that you both joined AFINet, and I hope we have many fruitful collaborations with your countries in the future. So thank you. I'm now going to pass over